Very good morning to all of you, and I will not talk about acute liver failure because Dr. Shiva has discussed it in length, and we can take a separate talk on acute liver failure because they are totally different diseases. So what I'll focus in the next 30 minutes is on acute and chronic liver failure, the mechanism and the spectrum of renal injury. So what I did was to take a case scenario because that will make us understand what we are talking about. So this was a 39 years old gentleman which was received in our ICU who was having portal hypertension, grade 2 varices, acute and chronic liver failure, alcohol related, and that is what is the predominant class of patients that we see. This patient has a clear history of jaundice followed by ascites, came with decreased urine output and breathlessness. He had very advanced liver disease, child score of 12, MEL 41, SOFA of 14, ARC 12, and grade 3 ACLF. And he had taken LAMA, and this was a patient who was received with a shock. There was tachycardia, Q-SOFA score of 2/3. He had tense ascites with IAP of 18. We can see the chest x-rays here. We can see here the labs, TLC count of 24,000, high NLR ratio, INR of 7, creatinine of 2.2, bicarbonate of 15, but non-oliguric, 50 to 60 ml per hour on catheterization. This was the rotum, and his ascitic fluid analysis did not show any SBP. So this patient had mild shock and requiring low vasopressor support, and the focus was a nosocomial pneumonia. The echo was normal. So what we are going to discuss here is how do we manage and how do we analyze the spectrum of such a case of non-oliguric stage 3 AKI in a patient with ACLF who's meeting almost relative criteria for dialysis. So when we talk about acute and chronic liver failure, it's very important for us to understand the pathophysiologic basis. So like I showed in my patient, here the patient had liver failure and subsequently developed kidney dysfunction. So liver failure is a driver, and that is the first thing that we need to remember in patients with acute and chronic liver failure. So kidney will follow the development of liver failure, and it is associated with worse outcomes. But what the APACL gives us is that there are two organs of utility. The organs of utility here means that kidneys and brain, if we salvage, these patients can still go on to a liver transplant. While there are certain organs like circulation, respiration, so if these fail, these become the organs of futility. So our patient has mild organ dysfunctions, some circulatory dysfunction, respiratory dysfunction, and obviously he also had a kidney failure according to the definition by the Easel-Cliff Consortium. So when we look at the pathogenic mechanisms of AKI in patients with acute and chronic liver failure, we need to remember that it is ischemia, like circulatory dysfunction, there is microcirculatory failure, endothelial dysfunction, there is inflammation. Inflammation is a main driver, and there is a cytokine storm. There is toxic injury to the renal tubules by bile acids. There is iron-mediated injury, which we as a group have also shown, and there can be injury due to nephrotoxic medication. So all these can be important contributors to AKI in patients with ACLF. And long back, we showed that we should have a different management protocol for acute and chronic liver failure because these patients have renal involvement which involves systemic inflammation. This large cohort of patients, we showed that the leukocyte count, the ferritin, the MEL scores are much higher in these patients, making kidneys more susceptible to the injury, and they very quickly succumb to multi-organ failure and die if they are not properly managed. So how do we find out and why the kidneys behave differently is that because these patients have more structural AKI, and structural component is also there in these patients even if they have hepatorenal syndrome. And how did we determine here was with the presence of urine microscopy, because time and again this is the only important test which we should be looking very carefully to find out whether these patients have granular cast which can demarcate the presence of ATN, where your vasoconstrictors like terlipressin could be very disastrous. And similar data from the Chinese group with the help of biomarkers, a very similar paper in hepatitis B-related chronic liver failure, they showed that all the biomarkers, urine NGAL, the urine liver fatty acid binding protein, all these, kidney injury molecule 1, all these were elevated in patients with hepatitis B related acute and chronic liver failure as compared to decompensated patients with hepatitis B and chronic and other groups. So what does this suggest is that these patients have structural AKI, and one of the important component is the systemic inflammation. So there is damage due to circulating dams and PAMs. And what is important here is there is intense, because of the severe vasodilatory state, and these patients go on to develop acute portal hypertension, these patients have intense vasoconstriction. So tissue hyperperfusion is there in patients with acute kidney injury. There is mitochondrial dysfunction, and I'll show you data. This is the data from the CLIF consortium. We do not go by these definitions, but the concept is very important. So in patients with acute and chronic liver failure, what they showed here was using the metabolomics approach in the plasma in a large cohort of ACLF patients of 181, which were compared with acute decompensated patients with cirrhosis, they showed that there was a reduced mitochondrial function, and this was causing increased, and this was due to systemic inflammation, which clearly correlated with the presence of systemic inflammation, increased glycolysis and related pathway, and accumulation of, because of the failure of the fatty acid beta oxidation, there was accumulation of the free fatty acids. And from the similar cohort, they also showed that systemic inflammation also dysregulates the amino acid balance in these patients. So what happens is that there is increase in the amino acids involved in the purine and the pyrimidine synthesis, and also in the synthesis of the antioxidant glutathione. So all this happens due to systemic inflammation. There is increased proteolysis, and this is all the metabolomics data which has come up from the EASL-CLIF consortium to show what is happening in these patients who have systemic inflammation. And another very important pathway which is important in these patients is the tryptophan metabolism. And there are multiple studies, not in acute and chronic liver failure patients, but also in patients with AKI and chronic kidney disease, that kynurenine is a very important pathway which gets dysregulated in patients with acute kidney injury or chronic kidney disease. And why this kynurenine is important is because this, the downstream metabolic pathway leads to the synthesis of the NAD, and NAD provides energy. So what happens here is that the tryptophan degradation pathway, and if there is accumulation of these kynurenine metabolites, this is more often seen in patients with acute chronic liver failure. And this is again the work by Professor Moru, which was published 2-3 years away. Now, in our group, we have also shown that systemic inflammation, and this is the data from the ARC done by Ashok, who showed that in patients with acute and chronic liver failure, there is a concept of golden window. So what do we mean by golden window is that patients with acute and chronic liver failure have systemic inflammation, and we believe that this systemic inflammation will progress through the development of sepsis and organ failures, which includes kidneys, and this is associated with poor outcomes if it remains unresolved. So Hrs is a very important target of therapies which we should be considering for preventing the development of organ failures. And if your patient develops organ failures, it becomes important that we treat systemic inflammation aggressively. Now, what about the time frame of AKI? And this is the data from ARC where we showed that we can have three types of patients. One is where the patient gets AKI. So you can see here, within the first 7 days, and has a very rapid downhill course until you are able to resolve this. In the black line is the patient who had normal kidneys and subsequently developed AKI. And in the green is where the patient remains normal and comes with the AKI and gets back to normal status. So what the data from ARC suggests is that the kidneys get involved in the first 2 weeks of the presentation to the hospital, in the hospital setting. We are not talking about patients where the disease started. So wherever the patients have been admitted, and we showed that in this paper in the large cohort of ACLF patients using a derivation and a validation cohort, that patients of acute and chronic liver failure, these are the components. So using the PYRO model, we showed that a high bilirubin above 12, a high urea, creatinine, injury due to nephrotoxic drugs, again, systemic inflammation, and circulatory dysfunction. So these are the important factors which will go on to development of AKI in patients with no AKI, in patients with acute and chronic liver failure. So we should be evaluating these in the patients at admission in patients who have no AKI. And again, data from our group and by Dr. Suman. She had done an analysis of the postmortem kidney biopsies, and she has shown that in the histology, the coulommic nephropathy was seen in 72% of patients with ACLF and 27% of the patients with decompensated cirrhosis. In animal models of bile duct ligation, which is a model of acute portal hypertension and jaundice, again, the kidney injury has been shown to be secondary to the coulommic nephropathy. So we know that with some data from histology done in the postmortem and in the animal studies, that because these patients are deeply jaundiced, there is toxicity due to bilirubin, there is a proposed toxicity due to bile acids, systemic inflammation, and this can be seen as the presence of bilirubin crystals. And these patients have tubular dysfunction and an intermediate form of functional and structural AKI. So in patients with acute and chronic liver failure, I'll not go into the details of definition, but we know that urine output becomes very, very important. So we should be using the urine output criteria because these patients can quickly develop AKI. And this is our ICU data of patients which included both acute and chronic liver failure and acute decompensated patients with cirrhosis, wherein we showed that systemic inflammation, infections due to multi-drug resistant bacteria, elevated bilirubin, and the number of extrahepatic organ failures were determining AKI. Now, this is the only prospective study which is available, which shows that urine output precedes changes in the AKI. So you should not rely on your creatinine measurements, and that is what I keep teaching every day to the residents. Don't go by creatinine. You should look at the urine output. We are doing blood gases. We should look at the metabolic acidosis and other parameters to pick up AKI early on in these critically ill and severely sick patients. Now, the spectrum of AKI, to make it very simple, can be either functional or structural. The functional is a AKI which has very good outcome. It responds to the volume resuscitation, and you can have a volume non-responsive AKI, that is the Hrs AKI, where you need to give your vasoconstrictors. The structural AKI in majority, these patients will be volume non-responsive. So we should not be pumping in too many fluids in these patients. So the diagnosis and of the spectrum becomes very, very relevant when you initially evaluate your patient. So how do we do that? And with multiple studies there is no study in ACLF which suggests about picking up any other form of structure. So we go by urine microscopy. There are not many studies on urine biomarkers. And we go by simple criteria that the patient has a spot sodium which is less, will be more likely to be Hrs, and these, we can see here the urine microscopy pictures, how clearly the kidney tubules or the kidney injury is reflected in the urine microscopy. And this is a systematic review and meta-analysis of all the studies on biomarkers, because this makes our life easy, because many a times our urine microscopy is not properly read or it's not properly reported. So we go by biomarkers which are more accurate, and what has been shown in patients with decompensated cirrhosis is urine interleukin 18 and lipocalin-2 can be two interesting biomarkers. So while we were doing our project of evaluating biomarkers for patients with ACLF, and we clearly looked at the urine microscopy, we were amazed to see not just two phenotypes, but three phenotypes. And I've shown you pictures over here. This is the Hrs patient. This is a patient of coulommic nephropathy, which we see here. There are some renal tubular epithelial cells. They are bile cast. These are not granular cast. These are bile cast, bilirubin crystals. And we can see here patients of ATNs. So what we did next was to evaluate a set of 17 urine biomarkers, and this was the cohort of patients, just to show you that these patients look so similar. So 15 patients in ATN, coulommic 15 patients, hepatorenal syndrome 15, and no AKI. And we can see here all had a similar MELD, similar bilirubin 22, lowest in the patients with no AKI. Creatinine also was almost similar, if you see here. So very difficult, bicarbonate same. So what we did here was to take up very similarly looking patients. All these patients were managed as HRS in different units. And we see here clearly the PCA plots. This is the no AKI group, this is the colemic, and this is the HRS and AT. So some overlap, but all these patients are distinctly different. And similar data we found when we looked at the markers of tubular injury. Patients with ATN had the maximal injury, as can be seen here with the levels of urine cystatin C, renin levels. Renin is a marker of circulatory dysfunction. NGAL, all were markedly higher in patients with ATN. And repair markers, they were higher in HRS and colemic patients, much suppressed in ATN. We can see here the blue dots. And the repair markers were markedly elevated in the colemic group as compared to HRS. So when we use the linear discriminant analysis approach, and this work we presented this year in the ASLD meeting, we found that NGAL level above 1100 and a renin level above 9.4 could accurately detect ATN. And between HRS and colemic nephropathy, if your patient had a renin above 1.34 and low levels of this could differentiate colemic from HRS. Another interesting finding we found here was when we analyzed the bile acids in all these 4 sets of patients, we can see here that patients with colemic nephropathy had the maximally elevated bile acids. And this is the heat map, which clearly shows a distinction of all the systemic inflammatory cytokines in these patients. So this clearly suggests that colemic nephropathy is a distinct group. And the blood metabolomics approach, why I showed you the data from ACLF CLIF consortium, is that we can see here that all the metabolites, and this is we compared colemic nephropathy with acute tubular necrosis using the plasma metabolomics. We can see here that there was an upregulation of primary bile acid synthesis. So this almost validates our findings, and there is a clear distinction of these metabolites. About 151 were upregulated and 39 were downregulated. So the pathways were almost the same. Similar findings we found in the urine tubule epithelial cells. I cannot go into the details of this. And these findings were also corroborated with renal histology. We did the mitochondrial function in the by looking at the genes in the tubule epithelial cells, and we found that patients with colemic nephropathy, they had a preserved mitochondrial function as compared to acute tubular necrosis. So you can achieve renal recovery in these patients. Now let's go back to our patient. This patient also had bile cast. We can see here the bilirubin crystal, and the urine biomarkers in this patient, the renin level was 1.4. The NGAL was below 1000. So this patient met the diagnostic criteria for colemic nephropathy also based on the biomarkers. The KIM1 was high and the OPN was high. The urine PCR was high. The spot sodium was 39 in this patient. And all the inflammatory biomarkers were elevated. So we go on to the management, and this is again the data from ARC, where we showed that albumin could be one therapy to prevent AKI development. And how albumin will act is that this is the data from an animal study, where they showed that in patients, in the animals, the albumin resuscitation was able to improve the cardiac inotropic function as compared to normal saline and the hydroxyethyl starch. So if you give albumin, what happens is that you have a decrease in the plasma renin activity. This becomes important, like I showed you. The renin levels were higher, stating a higher level of circulatory dysfunction, and they showed that the albumin and the cardiac dysfunction here was due to the elevation of the inflammatory cytokine pathways, the NF-kappa B and the INOS, and the albumin was suppressing this. Now, the data from our group by Dr. Rakesh Jagdish thesis, they had clearly shown that the albumin can prevent and can improve the mitochondrial function in patients with ACLF. Now, so we have to give an appropriate volume of fluid in these patients. The choice of albumin, we do not know whether it should be 5% or 20%, whether we should be using crystalloids in these patients. And obviously, with the current, even though there is no data on patients with liver disease, we would suggest dynamic indices for fluid responsiveness. For 5% albumin, we showed in septic shock patients, these were not ACLF patients, that it can improve sepsis-induced hypertension. And recently, our paper has been accepted in JHEP, where we showed that 20% albumin is also good as a volume expansion in patients with decompensated cirrhosis. Almost 20% of those patients were ACLF, and plasma light was non-inferior because albumin caused more side effects in these patients. So in ACLF, we need to see, and we need to be very careful that we should not let these patients go into hypovolemia. So how do we do that? We can do by different indices. We can use the intra-abdominal pressure monitoring systems, and we do that regularly in our ICU, and in ventilated patients, wherever we can, we go with extravascular lung water measurement, which can tell us, and which can be a very good guide of what amount of fluid should be given to these patients. Now, coming very quickly to the hemodynamic management. So how do we do that? We need to improve the mean arterial pressure, because we know that a higher mean arterial pressure is associated with improvement in the renal outcomes. And in this year ASLD, we showed that in patients with decompensated cirrhosis, even though there was no difference in the high versus low target map, but definitely an improvement in renal outcomes was seen. And patients we were trying to target a higher map, they get more side effects. So we should not be, like we do for fluid responders, we should not give fluid in non-responders. Similarly, if your patient is not responding, please do not pump in vasopressors, because they get side effects. Patients who improve, they will have improvement in the map, and they will also improve their renal function. What about targeting SVR? And this is the data of cirrhosis patients, where we showed that SVR is a more important parameter. A vasodilatory state in patients with cirrhosis was associated with more AKI and renal outcomes. But this is not in context of ICU, and this is what we see in patients with ACLF. This is the data from where they showed that in patients with ACLF, the hemodynamics is almost similar to patients with decompensated cirrhosis. Even in sicker patients with the ACLF, you will see that the SVRs may be lower as compared to decompensated. These were outpatients. Now, we've shown that in patients with acute and chronic liver failure, there is a challenge to manage the HRS, because the response to terlipressin is just 35%. And we can see here that if we use the most sensitive criteria, in this original paper, we use the criteria of 1.5 value of serum creatinine, but subsequently in Dr. Vinod's paper, we use the AKI criteria, that is going with relative elevation, and we were able to achieve a response to terlipressin in 40% of these patients. Now, in this paper, we showed that as against the data for decompensated cirrhosis, where terlipressin was shown to be as good as norepinephrine, in patients with acute and chronic liver failure, we showed a superiority of continuous infusion of terlipressin using the more sensitive criteria, and we showed that the terlipressin infusion was able to achieve the reversal of AKI in most of these patients and was superior. But what is important here is we can see here is almost 70% will go on to require renal replacement therapy, and the adverse effects become a challenge in treating the terlipressin patients. Now, we go back to our patients, and we see here that this patient had a lung water of 13. He had a SVR of 389. He had been given 2 liters of fluid because based on the dynamic indices. And because this patient was appropriately given appropriate amount of fluid, we started him on terlipressin, and we added a dose of 1 mg as a continuous infusion over norepinephrine, which he was getting for his circulatory dysfunction. Now we go on to the management of Hrs AKI non-responders, and we know that what are the problems with why do these patients have non-response as compared to, because there is a delayed diagnosis, so we have to go with urine output, and the most sensitive criteria for AKI, maybe biomarkers should be evolved in this area, and the misdiagnosis, and therefore we say that everybody is not HRS, we should not start everybody terlipressin, we should identify the patients who have tubular dysfunction or structural AKI. Cardiac dysfunction, another very important factor, because if the patient has poor cardiac reserve, these patients will not respond. Systemic inflammation and shock and adverse effects are the problems. So how do we identify non-responders? And this is the work which we did, and we presented this year. And we showed the relevance of 2 important biomarkers, urine NGAL and cystatin C, in identifying terlipressin non-response, dialysis, and also predicted these biomarkers were also able to predict mortality, because if you improve renal outcomes, you can improve their survival. So if you see the ARC grading, patients who were more likely to non-respond were the patients who had more severe liver failure. Because again, I showed you that liver failure is driving, so the higher the severity of liver failure, the higher was the chances that your patient will not respond to terlipressin alone. We can use the biomarkers, and in this data also we find around 900. So around 900 to 1000 NGAL is supposedly a marker to say that this patient will not respond to terlipressin alone, and we should be looking for alternative strategies. And we suggested two models based on the NGAL and ARC score or cystatin C above 2.5 and ARC score to show that which patients should be considered for early dialysis or an artificial liver support therapy, like Dr. Shiva was also showing. So this is the data for Hrs non-responders. This is our unpublished data. And we showed here that patients who do not respond, they have higher levels of the cardiac dysfunction markers. And this is the NT-proBNP and troponin T, which was markedly higher. And this was predicting the non-response, apart from the NGAL. And we did this dynamic, and we showed that patients who got adverse effects also, they had more cardiac dysfunction. So this is an important area which we should be seeing. Now, how do we manage the non-responders? We showed the utility of therapeutic plasma exchange, which improves systemic inflammation, and we know that systemic inflammation is a driver, even though plasma exchange was not improving the overall deaths, but liver failure-related deaths were clearly better and were improved as compared to standard medical treatment, and patients were managed by the artificial liver support that we evaluated here was the Prometheus. So we are not using Prometheus now because a lot of sepsis, the coagulation failure, and the problems were encountered, the adverse effects were more. So we are going with plasma exchange as the most as an important therapy to combine and to use in patients with acute on chronic liver failure. And again, another very important concept is that you should not feel that if you've done plasma exchange, everybody will respond. Everybody gets a decrease in the cytokine profile. But when we compared the responders from non-responders, we showed that in plasma exchange responders, we can see here that the HMGB1, which is an important damp molecule, was lower. So you've done this therapy early. They were not very sick patients. And the IL-1 receptor antagonist levels were elevated. There was improvement in the innate immune function. The monocyte phagocytic function and the mitochondrial oxidative burst was improved in the responders and did not improve in the non-responders. And this is the data of patients with coulombic nephropathy. We can see here that everybody where we gave plasma exchange and had renal dysfunction, there was an improvement in the cytokine profile and the bile acids. But if you do this plasma exchange in patients who have ATN, just see this, opposite. The endotoxemia is significantly elevated. So these patients get sick. So we should be choosing our patients for plasma exchange with renal dysfunction. The patients with coulombic nephropathy, we can see here improvement in the ENOS, ferritin, but there was an up. If you do plasma exchange in patients who have renal dysfunction due to ATN, these patients get more adverse effects. The bile acid, I showed you the total bile acid, but what about the the profile? So clearly there is a difference in the profile of bile acids also. This is a metabolomics data, Dr. Vinay's thesis, where we compared standard medical treatment with plasma exchange and bilirubin adsorption therapies, and we showed that the bile acid levels and the type of bile acids were also different in these patients. And these are the good bile acids which were improving in the survivors at day 7, while in plasma exchange there was a rebound increase in the cytokine heme adsorption therapy, they were decreased. So this patient, we did plasma exchange. We can see here the parameters had improved, the INR had improved, and the parameters of systemic inflammation also showed an improvement. But these are the adverse effects. So this patient did get, he already had a bad lung, and this patient did get some form of increase in the lung infiltrate. So there comes the role of adsorption therapy, and I showed you this data by Vinay. This is unpublished. We are in the process of publishing this data to show here, again, the severe liver failure patients and those with elevated bile acids. And the most important part here is that if you compare heme adsorption therapy with plasma exchange, the adverse effects were significantly lower with the heme adsorption. So in sicker patients, maybe this is a better therapy where you get lesser chances of adverse effects. No, this is bile acid hemadsorption. Now, very quickly, I'll touch upon dialysis because so dialysis is again, and we can stratify with the help of simple scores that which patients would require dialysis. This patient, and if we compare SLED and CRRT, this is our old data in the process of publication where we showed that CRRT was associated with worse outcomes, but CRRT was done in more sicker patients, and these were not matched patients. And to understand whether CRRT is better or SLED is better, we need a randomized controlled trial in patients with ACLF. And this is, ma'am, what you were talking about. This is our own data of acute liver failure patients. And if you see here comparison of patients who were given CRRT alone versus standard volume plasma exchange with CRRT, we can see here that the arterial lactate levels, the ammonia levels were not improved. If you combine it with plasma exchange, you can see and achieve a rapid improvement. So rather than targeting very high flow rates of CRRT, what we do in our ICU is to go with a combination therapy, and we do not do CRRT for all patients. We use it in non-responder patients to plasma exchange. In patients with acute and chronic liver failure, this is a data of 30 patients where we showed that it's not that everybody responds, and maybe this the colemic patients are which respond better. So 58% of these patients who were dialysis responders had colemic organ dysfunction.
Summarize maybe, Rakhi, sorry.
And the responders had improvement in all the parameters, but non-responders more likely had bleeding complications and they died. And what we propose is that if your patient gets shock, the time to CRRT, each hour delay, like for antibiotics, same for each hour CRRT delay is associated with a 7% decreased chances of renal recovery. In this patient, we started very early CRRT soon after plasma exchange, and we can see here all the markers improved. The shock resolved, there was an improvement in the colemic organ dysfunction, and the sensorium improved by day 3. This is the X-rays. This patient improved. Even the urine microscopy had shown resolution of bile casts. There was an improvement in the hemodynamics, and this is what we propose, and this we had proposed in the ARC consensus as the algorithm for management of ACLF patients with AKI. What we need to do is to do the Kirigo staging, do a proper imaging, rule out CKD, consider the dynamic indices. The best is the IVC diameter and collapsibility, remove all the offenders, give volume expansion, individualized, response-guided, add crystalloids wherever necessary. If your patient has progression or persistence, consider volume unresponsive. Either it is an HRS AKI or non-HRS AKI. In the HRS AKI, we go with terlipressin, give as continuous infusion, monitor adverse effects. In non-HRS AKI, there is a time that we should go with early introduction of artificial liver support modalities, and once you achieve resolution, consider an early liver transplant, because these patients will ultimately die and you can just salvage them for a short while, and if you can achieve a complete recovery is what is the goal, but till now we have not been able to achieve that, and I would like to thank you for your kind attention. So I would like to acknowledge all the people who have been working hard, and we've been working very hard in this area to develop AKI and management protocols in this particular sick group of patients.